Now we'll look at the brief management of eclampsia. So how do we manage women when they come to our facility, then they present with severe preeclampsia or eclampsia? So the first thing that you need to do is to call for help. Make sure you summon other health workers or other medical aids so that you work in collaboration in management of such women. Then, as the daily routines that we do upon admissions, meaning the environment that we should put this kind of patients, they need to be safe because they can convulse anytime. So make sure that you remove any hazards in those rooms or environments which they are nested in. So if possible, make sure that you use beds with padded rails just to prevent falls or injuries. So in the same environment, uh, that's where we do all these routine investigations. That's why we catheterize these women. That's why we cannulate these women. So you do investigations. You can even collect samples you take for laboratory investigations like the HB. You can do urinalysis and the other mentioned investigations. And then also do some observations on these women. Do check the maternal well-being, the fetal well-being. Even put the woman on CTG so there is continuous monitoring of the fetal heart rate. Then based on the observations that we have done, that's where now those findings we have to explain them to the woman. Depending if there is any fetal compromise, let the woman know so that she knows or she's aware of the kind of management that is going to be offered to her. So based again on those investigations or observations that we have done, we can even resuscitate the woman following the principles of resuscitation, where if there is fetal compromise, commence some fluids, just in following the normal principles of resuscitation. So from there, you even prevent the fit if there are any fits or she has an impending um, she has got impending fits. Make sure that you prevent them. If she's fitting, you manage them. But how do you manage fits? It's first, it's by giving magnesium sulfate. But before administering magnesium sulfate, there are observations or precautions that we follow before we administer the same magnesium sulfate. One, they should be uh, present patellar reflex. So the patellar reflexes should be present. They should address the respirations. The respiration should be at least 16 beats per minute. Less than that, then it's a caution when giving magnesium sulfate. Then you also look at the aspect of urine output. The urine output, uh, it shouldn't be less than 30 mils per hour. But more than that, then we give magnesium sulfate. Then uh, even the blood pressure, you have to monitor it hourly at least. Then how do we give the same magnesium sulfate? Magnesium sulfate is given as a loading dose of 14 grams, where 10 grams of 50% of magnesium sulfate is given IM. Not forgetting to add a 1 ml of 2% lignocaine to it because this drug is very painful. Then a 4 grams of 20% magnesium sulfate is given intravenously IV over 5 to 10 minutes. So if the woman fits after giving that loading dose, we can even give 2 grams of magnesium sulfate. Then from there, we give a maintenance dose 4 hours after giving the loading dose. Then how do we give the same maintenance dose? Maintenance dose, we give 5 grams of 50% magnesium sulfate, not forgetting to add a 1 ml of 2% lignocaine. Then we give it on alternative buttocks every after 4 hours. Then at least the the doses of magnesium sulfate that the woman should be given, they are 6. Then you control the blood pressure, because definitely there is an raised blood pressure here. So drugs that we can give to control the same blood pressure is we can give nifedipine 10 to 20 milligrams. We can give hydralazine 5 to 10 milligrams, but monitoring the blood pressure, because we are trying to prevent hypotension. Remember the mode of action of hydralazine. Remember, we give hydralazine when this is diastolic is above 110. Less than that, then it's a caution giving hydralazine. We can even choose to give lobetalol. Um, you can give 100 milligrams or 200 milligrams depending with your hospital policy. You can even choose to give methidopa 250 to 500 milligrams. Then after controlling the blood pressure now, uh, with the summoned people, with the amount collaboration of health personnel, you look at now the obstetric management, how the woman subsequent management will be, like the mode of delivery, how should the woman deliver. So the mode of delivery is just based on the findings that you have done of the observations, both on the maternal and fetal side. So you look at on the maternal and fetal well-being. How is it? If there is any compromise, then you manage this woman, or the mode of delivery is cesarean section (CS). Then meaning the management now of that woman changes to, you manage her pre-operatively. Those things that needs to be done when a woman is undergoing a cesarean section or is being prepared for a cesarean section, she should also be managed like that. Then if there is no fetal compromise, then we can even choose to induce labor. But remember, uh, inducing labor, again, it's a caution, though it's recommended. But when inducing labor, meaning we are putting the woman uh, to be straining. Remember, strenuous activities, they are going to predispose this woman to have onset of convulsions again. So we can choose to induce or take for cesarean section depending with the maternal and fetal well-being. Any compromise, then it's CS. But if the woman is stabilized, then uh, you can choose to induce her or to induce the labor. Then after you have the woman has delivered now, look at now the subsequent management. What kind of subsequent management that you're going to offer this woman? Remember again, the continuous keeping the woman in a safe environment, continuous. You look at all that aspect. You look at which kind of position should these women attain. You look at continuous giving of psychological care, because this woman doesn't even know what is happening to her. She's worried. So give her adequate psychological care. Do observation post delivery or post operatively. Also, you look at what kind of medication. So there is continuous administration of magnesium sulfate as per maintenance dose, as per protocol. So you continue giving magnesium sulfate every after 4 hours. Then you put the woman on long treatment of hypertension, where you give methidopa, you be giving hydralazine, you can be giving lobetal, OBD, you can give uh, nifedipine. All those, they are long treatment of blood pressure. Then that is the brief management that you can offer to women with the eclampsia. But what effects or what are the complications of eclampsia on uh, both the mother and the fetus? So one, the woman can even have CVA. So let's just list them. So the woman can present with CVA, the woman can have acute renal failure, the woman can have liver dysfunctioning, the woman can have respiratory failure, the woman can have retina damage, the woman can have placenta abruption, the woman can have myocardial failure, the woman can have mental confusion, the baby can be born asphyxiated, the the woman can have IUFD, the woman can have preterm labor, the baby can be born prematurely, they, they can be stillbirth, they can be fetal brain damage. All these are the complications of eclampsia. But one aspect that we forgot, if after administration of magnesium sulfate, if there is toxicity, then we give an antidote of magnesium sulfate, which is calcium gluconate. We give 10 mils intravenously. So you give calcium gluconate 10 mils intravenously. So that is the brief management of eclampsia. Don't forget to subscribe on Thriver Academia Corner so that we keep you updated. Thank you.